the whole bone and everything is affected. And the main issue there is that that infection can spread throughout the body. It's mostly going to happen to people that aren't taking care of their teeth and those that are immunocompromised. All right, so next we were talking about the most common cancer of the oral cavity, and that was squamous cell carcinoma. Okay, these cancers are going to be more common in people over 40. They develop malignant tumors that have a poor prognosis. They tend to be hidden and painless because they're either on the floor of the mouth or sort of on the side or the lateral portion of the tongue. It usually looks like this white, thick curd or milk sort of look, like cottage cheese. And it will spread to the lymph nodes over time. Lip cancer is another type of cancer. Usually this is more obvious. We can see it. It's more accessible. It has a better prognosis. That typically spreads locally. And we'll also see that in smokers and especially people that smoke those pipes. You also might see that with your people that do the snuff, because if you're familiar with snuff, that's like a tobacco and they put it on the inside of the lip, between the lip and the gum. Kaposi sarcoma, that's going to be in your AIDS patients, and this is where they have those brown, purple-like lesions on the palate. And then the next picture was the squamous cell carcinoma. You'll probably see a better picture of that in your book. All right, then we were talking about the salivary glands. So I was talking about the sialadenitis. This is inflammation of the salivary glands. It can be infectious or non-infectious. So the infectious type usually affects the parotid gland. And we see that in people that have mumps. This is a viral infection. You can be vaccinated for it, but not everyone is. So we are seeing this actively happening right now in the United States. And it's all people that aren't vaccinated. This can cause problems for boys, okay? This can cause damage, sterility, damage to their testicles. The parotid glands are below and in front of the ears. You have two other pairs of major salivary glands, your sublingual, which is under your tongue, and your submandibular, that's under your jaw. Swelling known as parotitis can occur on both sides of the face. It's not always caused by the mumps. You can also have non-infectious parotitis, and this can be in your elderly patients or patients who are debilitated for some reason and they're not taking in enough fluid or not getting enough mouth care. So that's almost anybody in long-term care, because we know that people aren't going in there every day and meticulously doing that mouth care. And some of them that have dementia and stuff, you really can't. They won't let you. It's just more of a fight sometimes than what you're able to do there. And these clients do have a right to refuse in some of these long-term care or developmental centers. It's what your policy is as far as how often and how much they can refuse, and whether or not you have staff that are adequately able to do this. The most malignant tumor of the salivary gland is mucoepidermoid carcinoma, and that occurs mostly in the parotid glands. But I would know the squamous cell carcinoma, that's the one you're more likely to see. You should also know about the infectious parotitis versus non-infectious, that the infectious causes typically mumps, but it can be caused by other things. But mumps is typically a cause of that parotitis. Here you can see the little boy. He has the swelling on one side only. Another issue is dysphagia or difficulty swallowing. This can be from neurological deficits, muscular disorder issues like Lou Gehrig's disease or ALS, or from mechanical obstructions. It manifests itself as difficulty or pain with swallowing, inability to swallow large pieces of solid materials. So, like you'll see this with some people with their pills, they can't swallow them. Difficulty swallowing liquids. Neurological causes are things like infection, stroke, brain damage, achalasia. Achalasia is failure of the lower esophageal sphincter to relax. So remember, that's at the end of the esophagus, and that's what's helping move food into the stomach. It also prevents reflux. So achalasia is failure of the lower esophageal sphincter to relax due to loss of innervation. I would probably know that definition. Accumulation of food, dilation of the lower esophagus occur as entry of food into the stomach is delayed. Chronic inflammation can develop in the esophagus, and reflux of the food can lead to aspiration when the client's lying down. There's also an increased risk of esophageal cancer in clients with long-term achalasia. Muscle impairment can come from things like muscular dystrophy, Lou Gehrig's disease. We've seen with Guillain-Barré or Guillain-Barré, however you want to say that. Okay, that usually starts in your legs, works its way up. It will attack those respiratory muscles. It can affect swallowing. So anything that causes a muscular issue or neurological, that would affect those areas. Again, stroke, brain damage. The achalasia itself, know this definition. That's failure of the lower esophageal sphincter, LES, they call that, to relax. Other things we might see are mechanical obstruction. So congenital atresia, congenital means they're born with it. This is a developmental anomaly. The lower and upper esophageal segments are separated. So the food goes into a blind pouch when they eat. The signs of this are coughing, choking, and cyanosis, the 3 C's. Congenital atresia is a developmental defect in which the upper and lower esophageal segments are separated, forming a blind pouch. Reflex occurs in the baby with congenital atresia, so meaning they're born with it, and this causes aspiration. There's a fistula there that connects from one of the segments to the trachea. These babies are going to need surgery right away. You can't feed them. Okay, because if you feed them, they'll aspirate. Stenosis, narrowing of the esophagus, can
Miss
also
Loach,
be, yes,
I'm sorry, could you repeat the 3 C's again?
coughing, choking, cyanosis.
Thank you.
So they're coughing because they're aspirated. They're choking because food is going into the trachea instead of into the actual esophagus. And then, of course, cyanosis because that blocks the airway. Stenosis or narrowing of the esophagus can also develop. The acquired form is usually caused by fibrosis because of chronic inflammation, ulceration, or esophagitis. It can also be caused by things like radiation. Stenosis can result from scar tissue. Remember, when it's stenosed, it's narrow. There's a stricture there or something blocking. So, like that scar tissue is blocking the area. This could happen if they drank something that was corrosive, like lye or some other cleaning material. This says accidental. So, who would you expect to see that in? You guys have heard
Children.
about diabetes insipidus, right? where they're always losing water, water, water. When they do that, they become very thirsty. Okay. So, like in developmental centers where clients live that have both developmental issues and psychiatric issues, those clients are on something called lithium. And that lithium can cause them to develop what we call nephrogenic diabetes insipidus. So it'll make them super thirsty. They want to drink all the time because they're losing all this water and they're dehydrated. So what happens is these clients, they'll drink from anywhere. They'll drink from a toilet bowl. They'll drink from, um, they'll still things like coffee and fluids. If, let's say, your housekeeper left the door open and there was bleach or something in there, normal people would know not to drink it. But for them, they're thirsty. All they see is liquid. So when you talk about accidental ingestion, there you go right there. This client would run in there and pick it up and drink it. I've personally seen this happen where they'll drink whatever they can get their hands on because they're just thirsty. They don't know the difference between what they should or shouldn't drink. So, again, this accidental ingestion of these corrosive chemicals can cause scar tissue, can cause stenosis, can cause damage there. Esophageal diverticula. This is where you have little pouches in the esophageal wall, and they can come from congenital defects or inflammation. The problem is food can get stuck in the pouch and obstruct the flow of other food that's moving down the esophagus. It can lead to irritation, inflammation, scar tissue, and then these people can regurgitate it, which puts them at risk for aspiration. And some clients that you have, if you're especially dealing with developmentally delayed, they have regurgitation all the time. So you got to really watch them for aspiration. Sometimes their regurgitation's so bad, we end up putting them on tube feeds. So causes of that esophageal diverticuli can be congenital or acquired. Again, it leads to irritation, inflammation, scar tissue. And these clients will have signs of dysphagia. They may have bad breath because of the food stuck in the pouches, chronic cough or hoarseness where they don't sound right. And then tumors can be internal or external here. So some of the causes of dysphagia, that scar tissue in the esophagus, a tumor there that's pressing against the esophageal area, or those pouches where the food gets stuck. They're called diverticulum. This is your congenital atresia. So if you see there on the left in the top picture, those two areas are supposed to be connected, but they're not. So the food doesn't go where it's supposed to. And sometimes if you look on the right, there's another tube that comes off. And so instead of the food going down, it goes into the actual trachea and it causes aspiration. So there's two types, congenital atresia. That food ends up in what we call a blind pouch, and congenital tracheal esophageal fistula, where the body forms this fistula abnormally and the food goes into the trachea instead of going down into the esophagus. With the achalasia, you can see down there, okay, that lower esophageal area is affected, and that causes the food to back up because there's no innervation there, meaning no peristalsis is occurring down there. It causes food and things to back up there. The left is just showing that damage to cranial nerves 5, 7, 9, 10, and 12 could result in a problem like this. Esophageal cancer. This is mostly squamous cell cancer. Again, it usually starts in the distal esophagus. Tumors in the esophagus can either be circumferential, meaning they can grow around the esophagus and cause this stricture, or they can grow into the lumen of the esophagus. Both types will cause dysphagia. Esophageal cancer is associated with chronic irritation. So, common causes of this are chronic esophagitis, where you have inflammation all the time of the esophagus for some reason, achalasia, hiatal hernias can lead to this, alcohol abuse, and smoking. And these clients will have dysphagia. It usually doesn't happen until late, and prognosis for this type of cancer is not very good. It's poor. So here you see the squamous cell carcinoma of the esophagus. Again, these are in your book, so take a look because those pictures might be a little bit better. This is figure 1712 in your book. Next is hiatal hernia. This is where part of the stomach protrudes through the opening into the diaphragm, into your thoracic cavity. There are two types of hiatal hernia, a sliding one, that's the most common one. This is where part of the stomach and the LES move above the diaphragm, especially when you're laying supine. All right, in the standing position, then the hernia slides back down into the abdominal cavity. In the rolling one, part of the fundus of the stomach moves up through the enlarged hiatus into the diaphragm. Here, the blood vessels of the wall of the stomach can be compressed, and this can cause an ulcer. So this picture is just showing you a normal stomach versus the sliding hiatal hernia. Or the rolling one. Okay, C is the rolling one. Of course, they have to have two names for everything. The problem with the hernia, the hiatal hernia, is food can become lodged in the pouch of the hernia. This can lead to things like inflammation of the mucosa, reflux in the esophagus, chronic esophagitis. So it leads to things like heartburn because of that erosion of the esophagus, belching, increased discomfort when they lay down, and substernal pain that can radiate to the jaw or the shoulder. A lot of times they will have dysphagia because of the inflammation or because of food in the pouch. The chest pain after the meals is a common complaint here because the pouch becomes distended or inflamed. So they'll eat to relieve the pain. Small, frequent meals and not laying down can help with this. GERD. This happens with hiatal hernias. The severity of the GERD depends on how well the lower esophageal sphincter works. If you have a decrease in the lower esophageal sphincter or an increase in the abdominal pressure, that allows more of the gastric content tends to go back up into the esophagus or reflux. That's what the reflux is when the food backs back up into the esophagus. Again, that reflux is going to cause heartburn, usually about 30 to 60 minutes after they eat or at night. That heartburn is gastric acid that will cause inflammation and ulceration of the mucosa. Eventually, it's going to damage that area. So the person will develop fibrosis or strictures in the esophagus. Factors that can reduce the pressure there for the lower esophageal sphincter are reducing things like caffeine, fatty foods, alcohol, cigarette smoking, and certain drugs could also eliminate the discomfort. So, like your proton pump inhibitors, but just trying to eliminate certain things from the diet. So, those things that you would not want to eat that would make this worse are caffeine, fatty foods, alcohol, and cigarettes. Spicy foods could also affect this. Gastritis, this is inflammation of the stomach. Sorry, that's your GERD slide in case anybody wanted to see it. But you see right there, avoidance of caffeine, fatty, spicy foods, alcohol, smoking. Gastritis here, the mucosa of the gastric lining is inflamed. It can be ulcerated and bleeding. So we're always trying to keep that intact, but when it's not intact, then we develop this gastritis. Okay, so we have this irritation. It can be caused by infection, food allergies like shellfish or drugs, eating spicy or irritating foods. So, like people be, with those hot pepper challenges, if your body's not used to that, okay, you take all those hot peppers at once, that can cause damage. Too much alcohol, too much aspirin or NSAIDs, things that corrode the stomach or cause damage to the stomach. Anything corrosive, also chemo, radiation can cause damage here. So if the GI area is irritated, how's the person going to feel? So they may have anorexia, nausea, vomiting. That can vary with each person. Hematoemesis indicates some sort of ulcer or bleeding in the stomach. So remember, that's vomiting that blood. Epigastric pain, cramps. They might have a fever or a headache if they have an infection. Acute gastritis usually will fix itself. So that's what it means when it says it's self limiting. And usually the mucosa will repair itself, go back to normal. If someone has severe or prolonged vomiting, then they become dehydrated. They can lose electrolytes. They can develop metabolic acidosis. That may require some sort of treatment there. So, usually we'll try to give people things to stop the vomiting, like don't put any food in. If you're nauseous, try to take in fluids, um, as long as you're not vomiting. But when they can't do that, when they can't take in the fluids and they just continue to vomit or they continue to have diarrhea, then we have to give them things either IV, because obviously you're not going to keep giving them something if they're throwing it back up. That's going to cause fluid shifts, so they're going to need additional treatment. In chronic gastritis, this is caused by atrophy, so the mucosa shrinks. That causes loss of the secretory glands. Remember those glands, what they're secreting. So you have the parietal cells, first of all. What do those secrete? Come on, you guys know this. What do those secrete, those parietal cells? You better know it for the test. What do they secrete? Parietal cells. Come on, I know somebody on here knows this. Cat got your tongue?
Pepsin, tripepsin, hydrochloric acid,
Okay, hydrochloric acid.
and pepsinogen. Mm-mm,
Okay,
not pepsin.
pepsinogen is your chief cells. Okay, remember your chief cells secrete pepsinogen, and I called it Pepsi, remember?
Okay, yeah.
That's going to help break down the proteins. It's going to help convert um, to those peptides, okay?
Pepsinogen?
Yes, that's your chief cells. Your parietal cells are hydrochloric acid and intrinsic factor. Remember, that's back on
B12.
back in the beginning when we were talking about the digestive system.
Very, very good, sir.
It's going to be around slide 15. Okay, so the chief cells are going to help you with pepsinogen, which then converts to pepsin, which then splits the proteins. You got to know that. Your parietal cells are putting out hydrochloric acid and intrinsic factor, which are necessary for what?
B12 absorption.
B12 absorption. All right, so the loss of the parietal cells leads to achlorhydria, which is lack of hydrochloric acid and lack of the intrinsic factor. These are both required for absorption of B12. Infection with H. pylori is usually the main cause of this and usually present. Chronic gastritis is seen in people with chronic peptic ulcers, people that abuse alcohol, older people, people that have autoimmune disorders like pernicious anemia. These are associated with the type of chronic gastric atrophy. Most of the time, we don't know why. Signs of chronic gastritis: mild epigastric discomfort, anorexia, intolerance to certain foods, foods that are spicy or fatty. We may not even be aware that they have this. Chronic gastritis also has an increased risk for peptic ulcers and gastric cancer. So if a client has chronic gastritis, they're going to be more at risk for those things. Gastroenteritis is the involvement of the stomach and the intestines in an inflammatory process. This is caused by infection, but it can come from allergies to foods or drugs. We have inflammation of the gastric mucosa, and that causes the person to vomit, or inflammation of the intestines, causing that person to have diarrhea. We have impaired absorption and, in some cases, increases in secretions of certain things. Nausea and abdominal cramps are usually present here, and these clients will usually be really tired or malaise, meaning tired or fatigued, and they may have a fever. Some of the microorganisms can be transmitted from food and water that's contaminated with feces or fecally contaminated. Some infections are going to be mild and self limiting, but sometimes they become serious, especially if the person is immunosuppressed or we have aggressive strain, a virulent strain, they call it. So if it's food or waterborne, we'll usually see a bunch of people affected by it. maybe a whole community. So this means a lot of people will come into the emergency room or the urgent cares with the same symptoms. And they'll usually be explaining it to something or relating it to something they ate or drank. And because it'll be usually in a certain area, then we can start looking at things like that. Like, is the water affected? Did it happen just at a certain restaurant or a nursing home? Or is it affecting multiple nursing homes? Is it affecting multiple housing developments? If it is considered a disaster, then they'll start to put plan in place. Like sometimes in Trenton, you'll see announcements come out. It'll say, don't drink the water. Or it could be in Burlington, don't drink the water. And they'll tell you what to do if you need to use water, how to boil it, how to prep it. Rotaviruses can cause serious infection with vomiting and watery diarrhea. This can happen in young kids or during the winter months. Epidemics of gastroenteritis that are viral are common in daycare centers. So we have to be careful with hand washing and food handling. Infections of C. diff. So usually we see this in patients that are on broad spectrum antibiotics for long periods of time. And it's easily spread in the hospital and in nursing homes because, again, people aren't washing their hands. They're going from room to room. I just was in a nursing home the other day, and I see some of our nurses from Jersey College going in and out of rooms. They're not hand sanitizing before they're going in and out of rooms, before they're putting on gloves, before they're taking them off. You got to be conscious of this as the nurse all the time. All right, with the C. diff, it's gram positive. It acts as a spore until it gets into the colon. Then the vegetative form damages the intestinal mucosa there, and it causes diarrhea. A lot of different ones here that you'll see. Okay. Some of the ones that I would be aware of is your E. coli or traveler's diarrhea. This is when you have contamination of the food or the water. Salmonella, you guys should already be aware of that. That is when you have usually undercooked or raw eggs, but also shellfish and chicken. Chicken's a big one. Rotavirus, this is fecal oral. We'll see this a lot in daycare centers because people aren't washing their hands after they're doing the diaper changes. And botulism. Botulism is coming from poorly canned food or poorly canned or poorly prepared meat. So this is why when they have those 10-cent or can sales at ShopRite, they tell you to stay away from the dented cans. Okay, because those cans can have tiny holes in them that can allow these toxins to enter. And you might not even see the hole. It might be behind the label. It could be very tiny and cause illness. So E. coli normally in the body and normally harmless in the intestines. If it's infective, it can stick to your mucosa and secrete toxins, causing gastroenteritis, This can happen in kids in nursery school, or it can be known as traveler's diarrhea. So you traveled across the country, you used all those rest stops, you came home, and now you got this nasty diarrhea. And sometimes it makes you throw up too. They do have some invasive types. Okay. And one of them is Shigella. It can produce a toxin like Shigella. There's another one that causes persistent diarrhea in young children. That one's called aggregative. So just think about that as aggressive. They have one that's enterohemorrhagic. So that means that these people are probably going to have some sort of blood in the stool. And that can come from unpasteurized milk or ground beef that's contaminated. Again, most of these are going to be fecal oral in the way that they're transmitted. Peptic ulcer. This can be gastric or duodenal. So most of them are going to be in the duodenum. These are known as duodenal, but some are found in the antrum of the stomach. Those are known as gastric. So they'll be in the antrum or in that lower esophagus. Usually these are single, small, round openings or cavities that penetrate the submucosa. So there's been some reason there why acid or pepsin has penetrated the mucosa there. This ulcer develops, and as acid continues to enter that area, it can cause additional damage. The ulcers can go deeper into the muscles and eventually perforate the wall into that muscularis area and eventually perforate the wall. The area of inflammation will surround it. Erosion will evade the blood vessel wall there, and that causes bleeding. Bleeding causes small amounts of blood to be released. It could lead to also a hemorrhage, depending on the size of the blood vessel involved there. Most of them are caused by H. pylori infection. I would know that. Again, we have breakdown of the mucosa, allowing acid to get in there and penetrate and do damage. So this next slide is just showing you the area where all those little dots are, where these ulcers can occur. Chronic loss can be detected by the presence of iron deficiency anemia, or we can do one of those fecal occult blood tests. You might see it in the stool. That might tell us to look a little bit harder to find that ulcer. So the damage to that mucosal barrier causes the development of the ulcers. We end up with inadequate blood supply because of damage to the mucosal barrier. Also, damage can occur to that mucosal barrier from things like smoking, shock, stress, because it doesn't get enough blood supply to the area, so it damages the mucosa. Scar tissue can damage the mucosa, again impairing with blood supply. If the body is secreting too many cortisone, glucocorticoids, or if someone's taken large amounts of steroids, it can damage the mucosa of the stomach. Things like aspirin, NSAIDs, or alcohol can damage the mucosa. So any of these things causes damage of the mucosa. It can let the acid in to damage the lining to penetrate the wall, and the infection of the H. pylori also can cause the development of these ulcers. So we'll see increased acid secretions, increased gastrin secretion, can cause this. Increased vagal stimulation can cause increased acid to be secreted. There can be anomalies that can cause people to secrete too much acid. Alcohol, caffeine, certain foods can cause you to secrete acid. Interference with the normal feedback mechanism. So, interference with some sort of delayed gastric emptying. Or the stomach emptying too fast. Severe or prolonged stress that restricts blood flow, causing the chyme to sit in the area too long. Remember that chyme is very acidic. Stress, because stress can cause you to produce too much steroids. An increase in the amount of alcohol, caffeine, cigarette smoking, all those things can affect for these peptic ulcers. So healing is going to be hard here because lesions cannot be isolated from that irritant. Meaning we really have no way to protect the area from that acid or from that acidic environment. So even though it tries to heal, the granulation tissue that does develop there is sometimes damaged by the chyme. Remember that chyme is very acidic. Because they need a longer time to heal, that can cause development of scar tissue and fibrotic tissue there. Some of these ulcers tend to come back because of the damage there from the scar tissue. It interferes with the blood supply to the area. Again, the ulcers can damage blood vessels near them, causing rupture of the vessels, which also cause bleeding and other irritation there. They can also develop chemical peritonitis because the ulcer will erode those blood vessels. It can go through the wall. If it does go through the wall, that can allow chyme to enter that peritoneal cavity. That would cause that chemical peritonitis, inflammation of the peritoneal membranes and other structures in the abdominal cavity. Obstruction of the digestive tract can also occur from the strictures from the scar tissue. These ulcers are more common in men than women. And also gastric ulcers we see more in older people, those with scar tissue or those ones that regularly take things like aspirin or NSAIDs. So what are they going to feel like? Infection with the H. pylori is going to be the major cause. They'll have epigastric burning or aching pain 2 to 3 hours after they eat. So here, these people will eat to relieve the pain. That can cause them to gain weight. The pain is often relieved by ingestion of food or antacids, so they also might drink bottles of what? What do you think they're going to drink if they have heartburn?
Milk. That's it. Is
So
it
like
Pepto-Bismol?
Maalox,
Oh,
Maalox or Pepto-Bismol, yes. Now, Pepto-Bismol has qualities like aspirin. How many of you know that? It's made out of the same stuff that aspirin's made out of. So it can cause your stool to look black. Okay. And I'm sure it can cause some damage to the stomach. If you're drinking like Maalox or eating Tums and stuff like that, then what can build up? How about bicarb? Because that's alkalytic. Okay. And when people drink it, how many of you have ever seen people drink Maalox? None of you? None of you have those older parents and grandparents that walk around with the bottle just drinking it like it's a glass of milk? Well, definitely happens. Okay. They walk around the house, they drink it like it's a glass of milk, and they drink it, drink it, drink it. And it can definitely change the levels in your body of certain things, and it could put you into alkalosis. So, they have this heartburn, they have this nausea and this vomiting. So that could cause them to lose weight. But a lot of these clients will actually gain weight because they find out when they eat food, it makes them feel better. So whenever they start to feel this pain, they eat the food. If they do have vomiting, a lot of times that will happen like after they drink alcohol or they eat some kind of food that really irritates. All right, next is stress ulcers. These are associated with trauma or systematic problems. So, stress ulcers, especially your burn patients. So, usually we'll give them proton pump inhibitors if they have a major burn as soon as they come in. We want to prevent something called Curling's ulcers. There are other ulcers that they can develop, like gastric ulcers, and usually it's because of constricted blood flow to the mucosa. All right, so something is causing vasoconstriction there. We're not getting blood flow. The mucosa barrier is lost. Acid's able to get into the mucosa. With people with the Cushing's ulcers, sometimes it's from vagal stimulation. So remember, we said vasostimulation can cause additional acid secretions. The first indicator of a stress ulcer is usually hemorrhage because of the rapid onset, and it masks sometimes the primary problem of what's going on there. So there's your stress ulcers, all those little dots. Gastric cancer, this usually comes in the mucus glands. It's mostly going to be in the antrum or the pyloric area. Early carcinoma is usually going to be confined to the mucosa and the submucosa. Advanced gastric carcinoma usually involves the muscularis layer. The tumor will eventually go into the serosa, into the lymph nodes, the liver, the ovaries. Usually it's asymptomatic, this gastric cancer, and we don't see it until it's well advanced, and by that time it's too late. H. pylori is associated with a higher risk of gastric cancer. Diet is also a key factor. So preservatives, nitrates, smoked foods increase the risk. Genetics, we'll see an increase in family members and people with group type A blood type. Type A blood type. We'll have a history typically with chronic atrophic gastritis or polyps. So that's why they do the endoscopy, to look for those polyps. Usually these clients won't have symptoms that are highly seen. So sometimes they're vague or mild symptoms. They might have just generalized symptoms like anorexia or indigestion. Sometimes weight loss, sometimes fatigue, or sometimes they might just feel full after they eat. Surgery or gastric resection, along with chemo and radiation, are what we use for these guys. So early gastric cancer here. Dumping syndrome. This is where the gastric emptying control is lost. So you eat and it goes right through you. The food's not digested. Okay. So we have large quantities of ingested food that are rapidly dumped into the intestine. And it's because of the damage or loss of the pyloric sphincter. So a lot of times we'll see this after a gastric resection. So the pyloric sphincter, remember, is supposed to control how much food goes from the duodenum to the ileum, because that is where all the absorption takes place. Here we have that pyloric sphincter not working. So that food is getting quickly dumped into there. The storage in the stomach, which includes dilution of the chyme by the gastric secretions, is missed. The hyperosmolar chyme draws fluid from the vascular compartment into the intestines, causing intestinal distension and increasing the motility. So these clients, signs and symptoms, I would know this: abdominal cramps, nausea, diarrhea. They're also going to have hypovolemia and eventually hypoglycemia. The hypovolemia itself, hypovolemia, is going to cause dizziness, weakness, rapid pulse, and sweating. And that hypovolemia is caused because that hyperosmolar chyme is drawing too much fluid from the vessels in the body, and it's drawing it into the intestines. Okay, because the normal process isn't happening there. So that last statement there, that hyperosmolar chyme is drawing fluid too quickly from the vessels into the intestines. That causes distension there, an increase in the motility, which is going to lead to a decrease in blood pressure because of the fluid being drawn from the vessels too quickly. So these clients will have anxiety, syncope, dizziness, weakness, rapid pulse, sweating. Occurs shortly after meals, abdominal cramps, nausea, diarrhea, and then hypoglycemia 2 to 3 hours after the meal, because they ate this food and that stimulated, okay, the body to react to the high glucose level and secrete that insulin. But the food didn't stay in the body and get absorbed. So now we have this high secretion of insulin without the food being there to offset it. That drops the blood glucose level. So we can fix this by giving them small, frequent meals that are high in protein and low in simple carbs, meaning we need to give them more complex types of carbs. You can find that in certain foods that you eat. Some carbohydrates break down better. They're called complex carbs. And that's what we would want these clients to have. So meals that are high in protein and low in simple carbs. Babies are born with this. They look like little Buddha babies. They got a big belly, okay? And they're on TPN because they can't absorb the food. they can't keep up with the metabolism, the growth rate. So we have to give them TPN in order to get them all of the nutrients that they need for them to survive and be able to get past all this. And then we can do surgery on them. So one of the things that we might be able to do is increase their absorption area by transplanting more ileum, more of those villi in there that do the absorption. And also maybe fix whatever's going on with that pyloric sphincter so that it's controlling how much food is being dumped into those intestines. Because when that's not happening, then everything's getting dumped at once. The bridge is open and we're just dumping. So here you go. They eat. Okay. Either they had some sort of gastric resection or they were born with this. Either way, they lose the gastric capacity. They lose the pyloric sphincter, this large amount of undiluted chyme, which is very acidic, remember, is dumped into the small intestines that causes fluid to be pulled from the blood vessels into the intestines to dilute that chyme because it's so acidic, so hypertonic. That pooling of the fluid from the blood vessels causes the hypovolemia. That causes the symptoms: a decrease in the blood pressure, faint, dizzy, tachycardia, trying to give us more cardiac output, pallor, because the blood is being pulled from the skin to where the organs are that need it, diaphoresis. Okay, then they're going to have distension in the intestines because of all that fluid coming in there. That leads to pain, cramps, nausea, vomiting. They'll have rapid digestion and absorption of the food. Okay, so that's going to cause hyperglycemia and increase in the secretion of the insulin. Everything won't be absorbed. It's going to go right back out. So because of that, they end up with hypoglycemia about 2 to 3 hours later, tachycardia, pallor, diaphoresis. Got to know dumping syndrome. Pyloric stenosis. Okay, this can happen in older adults, but we'll see this a lot with newborns. Not a lot, but with the ones that have it. Okay, where the stenosis means what?
Narrowing.
Okay, so it's narrowing or it's not able, it's obstructed. There's nothing able to pass through there. Okay, remember that pyloric sphincter is controlling what's going into the duodenum and into the ileum. Okay, so when that obstruction occurs there, and again, you can be born with this or it can come from scar tissue later in life. These people are going to have what we call exorcist vomiting. So the vomiting comes straight out, it's projectile. And it happens after they eat. Usually they'll have a hard olive-like mass in the abdomen. In congenital form, the pyloric muscle there is hypertrophied and it feels like a hard mass. Signs of stenosis will usually appear a few weeks after birth. First, they'll have regurgitation, and then eventually it becomes projectile vomiting. And it occurs right after they eat. Okay, remember in ICP, increased cranial pressure, they also have projectile vomiting, but there's no food involved there. In this, it happens after they eat. These babies will not gain weight. They'll develop stenosis. They'll develop dehydration, and they'll have persistent hunger because they're vomiting up their food or regurgitating it. Stools will eventually become small and infrequent. And if it's a baby, they're going to need surgery. In people that have acquired pyloric obstruction, it interferes with gastric emptying, and that causes them to feel full all the time, and then they'll vomit after those meals. The gallbladder and the biliary tract, these are areas that are affected by one or more problems, usually that involve gallstones in some way. So cholelithiasis is the formation of the gallstones. These are masses of solid material or calculus that form in the bile. Cholecystitis, which is inflammation of the gallbladder and the cystic ducts. Cholangitis, which is inflammation of the bile ducts, and usually we have some sort of infection there. And choledocolitis, which is obstruction by gallstones of the biliary tract. So gallstones can be made from bile. They can be made from cholesterol, bilirubin, which is your bile. They vary in size and shape. They form in the bile ducts, the gallbladder, or the cystic duct. And again, they're mostly cholesterol or bile. Small stones, a lot of times, will go right out. People don't even know that they have them. And as they grow in size, then they can obstruct the bile flow or cause pain. It's usually colic pain, and I would know that. So the colic pain is that pain spasm that's trying to get rid of the stone. The presence of gallstones can cause irritation and inflammation in the gallbladder. It's going to cause problems wherever that tissue is, and it can cause infection to develop there. Infecting organisms are usually going to be E. coli, which are able to get into the gallbladder through the sphincter of Oddi or from the portal veins or the lymph nodes. When the stone obstructs the bile, then that colic develops. And that is severe spasms of pain from strong muscle contractions trying to remove that stone. Again, I would know that. Obstruction of the biliary system at the sphincter of Oddi can also lead to pancreatitis because it blocks the pancreatic secretions. Gallstones typically form when the bile has a high concentration of things like cholesterol, or if we don't have enough bile salts. Gallstones can irritate, cause inflammation, and then lead to infection. So risk factors are more common in women than men. High levels of cholesterol in the bile, high cholesterol intake, obesity, multiparity, which means birth to multiple children, using oral contraceptives. If you notice, a lot of these things are, again, surrounded around women, pregnancy, weight, hemolytic anemia. So that's going to be what? What are your two hemolytic anemias? Come on. What are your two hemolytic anemias?
RBC destruction, sickle cell anemia.
I'm sorry. Say it again.
Sickle cell.
Sickle cell and
Thalassemia.
thalassemia. Good. Alcoholic cirrhosis and biliary tract infections. Okay, so other than those three, a lot of these other things surround women. Not that men can't be obese, but obesity, pregnancy, multiparity, they all go together, as well as high cholesterol intake, because what do you like to eat when you're pregnant? Well, everything, but everything good, right? You like to eat those fatty foods, those juicy, good foods. All right, so obstruction of the duct by large calculi, sudden can lead to sudden severe waves of pain or that colicky pain that we're talking about. And that usually will happen in the upper right quadrant of the abdomen or the epigastric area. This can cause that referred pain. So the pain can go to the back and to the right shoulder. If the pain continues, a lot of times they'll develop jaundice. And that jaundice is caused by bile backing up into the liver and the blood. In this case, they might need the gallbladder removed. They might need the stone removed. Usually acute cholecystitis is associated with some sort of obstruction and inflammation. Severe pain usually happens right after they eat a fatty meal. They can have fever, leukocytosis, and vomiting with the pain. The pain will be increased for some time. And then if the stone is able to move on its own, a lot of times the pain will subside. Chronic cholecystitis is manifested with milder symptoms. Sometimes it includes intolerance to fatty foods, belching, bloating, mild epigastric discomfort. All right. You should know what jaundice is. Jaundice is that yellowing of the skin. Okay. So a lot of times we'll see that with destruction of the red blood cells. So those hemolytic anemias like sickle cell or thalassemia. It can occur anytime there's damage to the liver cells. So any sort of hepatitis or cirrhosis. What are your three hepatitises? The main ones, okay? You also have D and E, but the main ones are hepatitis A, which I call hepatitis ass because it's fecal oral. That's how you get it, okay? You change a dirty diaper, don't wash your hands. You poop, you don't wash your hands. You eat dirty seafood. You can also have hepatitis B. Hepatitis B be in all your body fluids, everything wet except sweat. So hepatitis B, a lot of it you get through blood transfusions, but you can get this from drinking after someone that has an active infection because it's in the saliva. Hepatitis C, I'll see you later, okay? Because these people are usually engaging in risky behavior like injecting IV drugs. You can also get this from a blood transfusion. You'll see a lot of people over 65 that might have it because of blood transfusions. You can also get this from cirrhosis of the liver or a virus. You can get drug-induced hepatitis. Certain drugs can cause hepatitis in someone. And then post-hepatic jaundice is typically caused by some sort of obstruction of that bile flow into the gallbladder. So the blood of that bile or that bile flow is backing up into the liver and into the blood. All right, we look at bilirubin, okay? Bilirubin is supposed to be broken down by the liver, okay? So, for example, levels of unconjugated bilirubin are going to be elevated in certain types of jaundice. Jaundice comes from increased amounts of conjugated bilirubin, which is directly in the blood. So the bilirubin has to be broken down in a certain way, is what all this is talking about. All right. Bilirubin typically goes to your liver for processing. And at that time, it's unconjugated, meaning that it can't be dissolved in water. And then the body will bind it in the liver to albumin. Okay. And then the albumin brings it to the liver. The liver then processes it, removes the albumin, and makes that bilirubin water soluble. Now that it's water soluble, the body can get rid of it. When it doesn't do that process, then it's dangerous and it can cross into the brain, okay? It can also cause that jaundice in your body. When it crosses into the brain, it can cause brain damage in the form of something called kernicterus. And you'll see that in sometimes in babies. So this is why we put the babies under the light. We try to get rid of the levels of bilirubin. Decrease them. All right, your liver has two major sources of blood. You have the portal vein that brings in that nutrient-rich blood from the digestive system. Remember, it brings it there, and it's going to get rid of any bacteria that came in with that food. That's why it's going there. Okay, and then it'll bring also oxygenated from the blood from the heart there. Okay, the lobules are there. Those are the functional units of the liver. You have your liver cells there. That's just detoxifying the blood, putting the blood either back into the system, getting rid of anything that might harm you, and then putting some of the blood into the superior vena cava so it can go back into circulation, get deoxygenated and go back get oxygenated and go back into circulation. So in hepatitis, I explained to you the three types, what's actually happening here. So you have inflammation in the liver. Usually if it's caused by alcohol, it'll cause the liver to become fatty. But there are some other things that can cause it to become fatty. Most of those are idiopathic. So they don't know why some of these non-alcoholics develop a fatty liver. But once it becomes fatty, it's not going to work as well. Any sort of inflammation is going to impair those liver cells, and it can cause inflammation, necrosis, and obstruction of the blood and bile flow. It can also impair the liver cells themselves. The liver itself has good functional reserve. It usually can regenerate itself, but certain viruses can affect the cells there and damage it. Again, you have hepatitis A, hepatitis B, hepatitis C. Any questions on those? Hepatitis D is usually in someone that has a hep B, but usually not in America. We usually see this in other places. Okay. But if they have hep B, they can develop this hepatitis D. Hepatitis E also can happen, again, usually in third world countries, and that also is oral fecal. All right, so what are they going to feel? In the initial stages, they'll be tired, they'll have malaise, anorexia, muscle aches. That's your pre-icteric stage, and it really doesn't matter what type of hepatitis that they have. In the icteric stage, then they start to develop jaundice, and that's because of the obstruction of the bile. The stools will become lighter in color, sometimes like a clay-like type of color. Okay, so that is indicative that something else is happening there. Also, because your liver now is becoming enlarged, it can become sore or tender. This is going to affect your blood clotting times and your synthesis of your blood clotting factors because that all happens in the liver. And then the post-icteric stage, usually your hepatitis A can be 8 to 10 weeks, but hepatitis B could be over 16 weeks. So for that long of a period of time, these people can become ill. So usually with hep B, they have exposure to the virus. All right. Then they have a little bit of an incubation period. Some people will become carriers. So they don't actually get the disease, but they can give it to somebody else. They develop that infection over 4 to 12 weeks. Then you have the pre-icteric stage where they feel tired, fever, joint pain, then the icteric, where they become jaundice. If they have a fulminant infection, that's a severe infection, and that could lead to liver failure. That's what that means. And then usually after the jaundice, if they're being treated, okay, they'll have a recovery stage. There's no way to destroy the hepatitis virus in the body. So we use things like rest and a diet high in protein, carbs, and vitamins. With cirrhosis, you have destruction of the liver. Causes are alcohol, immune disorders like SLE, stones or cystic fibrosis, chronic exposure to toxic materials, or some sort of storage disorder like hemochromatosis, meaning the way that it's storing things in the liver. So these clients are going to have fibrosis. Remember, with fibrosis, those cells, that tissue is not going to work. They lose function of the lobes. So we were just talking about the lobes and how they help with absorbing nutrients, with removing certain bacteria, and with helping to oxygenate the blood there. So even if we remove the cause, because of the fibrosis affecting the blood supply to the liver, these people can still have damage. The liver will become enlarged at first, but then it starts to become shrunken because of the fibrosis. Degenerative changes are asymptomatic until the disease gets well progressed. The biopsy of the liver can determine the cause and the extent of damage. Progressive changes will occur in the biliary, and post-necrotic cirrhosis are directly linked to inflammation, necrosis, and fibrosis associated with the primary condition. So because of the way it's going to damage the liver itself, that's how it's going to interfere with that function. So if you look at this liver here, okay, this one's caused by Hep C. And you can see the inflammation there. The damage to the tissue, that's going to interfere again with nutrients, with blood supply. With cirrhosis, first they have the fatty liver stage. The liver becomes enlarged. This stage is usually asymptomatic, and if they stop drinking or slow it down, they can reduce this problem, and sometimes the changes can be reversible here. In the second stage, they may start to develop malnutrition. That can cause damage to the cells. So again, their primary function here for an alcoholic is to drink. They don't eat a lot, and they're not taking in a lot of the vitamins, so they become malnutrition from that because their meal is going to be that alcohol. So they have this malnutrition, okay, and originally they already accumulated those fat cells causing the fatty liver. Now we have inflammation and necrosis in the second stage. Fibrosis starts to form. That's not reversible. So sometimes we can reverse the fatty cells, but not the fibrosis. Again, this stage could be asymptomatic, or they might have mild symptoms like anorexia, nausea, a little bit of liver tenderness. Sometimes they only feel this if they take in too much alcohol. If they do enough damage here, okay, they can end up in liver failure, encephalopathy. Remember, I talked about that Wernicke's encephalopathy, where their brain's not functioning here. The third stage or end stage cirrhosis is reached when the fibrotic tissue replaces the normal tissue. This alters the structure of the liver and it's not able to function. They'll develop portal hypertension. Sometimes those esophageal varices we talked about will start to bleed, and they have impaired digestion or absorption during this time. We'll also see a decrease in the body's ability to remove or conjugate the bilirubin. They're not producing as much bile. That's going to interfere with their ability to digest and absorb nutrients. The blood clotting factors are not being produced here. Also, albumin is being lost. So they'll develop ascites in that stomach because remember, albumin is holding that fluid in the vessel. That's that water magnet. They're losing albumin. That's going to cause that edema or that ascites in the belly. They'll also have impaired glucose and glycogen metabolism here because the liver does that as well. The body won't be able to detoxify some of those drugs or get rid of some of those hormones or remove some of those toxins like ammonia. So you're going to have a decreased removal of toxins, a reduction of digestion and absorption, backup of bile in the liver causing jaundice, obstructive jaundice, blockage of the blood flow through the liver causing that portal hypertension, and then congestion in the spleen, increasing the breakdown of those red blood cells, which is just going to complicate things further. They're not able to absorb the iron and the B12 or store it. Spleen is congested here. Intestinal walls and the stomach, we have issues. So we have problems with digestion and absorption. Again, development of those esophageal varices. That's going to be bleeding in that portal area. And then the ascites. Okay, there's your bleeding esophageal varix there. And I talked before about there's a tube we have to stick down their throat and into there. It has a balloon on the end, and you got to try to tamp those areas to stop them from bleeding. You got to be very careful with it because if you leave it in there and walk out of the room, it can suffocate them if it slides out. All right, so development of ascites here, everything we just talked about. Review this slide. Know what peritonitis looks like. Hypotension, which means dizziness, sweating, tachycardia, board-like abdomen. All right, for cirrhosis, symptoms, fatigue, anorexia, weight loss, anemia, diarrhea, that dull aching pain in the upper right quadrant where that liver is, ascites, peripheral edema, bruising because of those blood clotting factors, jaundice, encephalopathy, meaning they're not going to be able to think straight. They can also develop something called asteriscus. I would know this. This is where they flap their hands. It's like a tremor. And it happens involuntarily. Confusion, disorientation, convulsions, coma, all these things from the brain damage, from the ammonia not being broken down, from the excessive bilirubin, itching of the skin, pruritus. That's from the icterus. So if you think about the icteric stage, that's that jaundice stage, okay? Itching. Liver cancer, okay? Hepatocellular carcinoma, that's the most common type. That develops from cirrhosis or cirrhotic livers. And then signs of liver cancer are going to be similar to other liver diseases. So anorexia, vomiting, fatigue, weight loss, enlarged liver, the portal hypertension, and the enlarged spleen also. Also paraneoplastic. Remember, that's when the tumor cell itself is producing things. Acute pancreatitis, you want to know this. So here we have inflammation of the pancreas and we have autodigestion of the pancreas. Remember that I said those pancreatic enzymes. Okay. There's something there called trypsinogen. Okay. The trypsinogen can convert the trypsin and trigger it. The trypsin converts other enzymes. So activated enzymes, trypsin, amylase, and lipase will start to eat the pancreas itself, causing inflammation, bleeding, and necrosis. Okay. So we have autodigestion of the pancreas by the trypsin, the amylase, and the lipase. Also, the body will release cytokines here and prostaglandins because the tissue here will become necrotic. This can be in that from that chemical peritonitis we talked about earlier. Other things can lead to this as well. Okay. But acute pancreatitis is a medical emergency. Remember, I told you that if you have people on valproic acid, you have to watch for this. Pancreatitis itself can lead to shock also. And it's a type of neurogenic shock. So chemical peritonitis is from that bacterial peritonitis. Bacteria in the blood can occur here because of this. This person can go into respiratory distress and kidney failure. Causes of acute pancreatitis. Gallstones. Alcohol is big. And I would know those two. If they're going to ask you about acute pancreatitis, they're going to ask you about gallstones and alcohol. A lot of times you're eating a large meal and then you take in a large amount of alcohol, and that can lead to it. Signs: epigastric or abdominal pain radiating to the back. Usually they'll curl up in this fetal position because that's more comfortable. Shock. So we'll see hypovolemia, low-grade fever because of the infection, abdominal distension, and a decrease in bowel sounds. Decreased peristalsis and paralytic ileus. So it's not moving here. All right, so look at this slide good and know it, okay? What's causing this? And it's because of these activation of these enzymes, and the enzymes are now eating the pancreas. It's going to lead to necrosis, inflammation, eventually shock, DIC, which is where we're producing more emboli and clotting factors at the same time. And the body ends up using up all the clotting factors and you start to bleed out. Or this neurogenic shock, okay? Peritonitis, which I already said is going to be that board-like abdomen. Hypotension, tachycardia, sweating. Pancreatic cancer, okay? This is terrible, pancreatic cancer. Depends on where you get it. Now, there is something called the Whipple surgery. So if you get in a certain part of the cancer, of the pancreas, we can fix it. I had two uncles that died from this. One of them was diagnosed in October. By the day after Christmas, he was dead. And he weighed 250 pounds. When he died, he was about 89 pounds. That's how quick it takes you out. They diagnosed him with constipation. Took him a whole month to figure out he had pancreatic cancer. In the months prior, he suddenly developed type 2 diabetes, which is one of a sign of this, because in pancreatic cancer, remember, that's where your beta cells are made. So a sudden development of diabetes can sometimes, doesn't always mean this is what you have, but it can be a precursor and something we should look at. Usually people will trend down or trend up slowly with their HbA1c. You know, the doctor's monitoring it, but they suddenly trend up, then you have to look at some other possible causes. Okay, so pancreatic factors for pancreatic risk factors for pancreatic cancer. Sorry, let me say that again. Risk factors for pancreatic cancer. Sorry, I'm trying to get through this because I know I said 11, but I'm trying to get through everything for you guys. All right, so risk factors here: cigarette smoking, okay, alcohol. All right, so pancreatitis and dietary factors. So having a history of the pancreatitis. The common form is adenocarcinoma, which comes from the epithelial cells. They'll have a tumor at the head of the pancreas, which causes obstruction of the biliary and pancreatic flow. Eventually, they'll develop weight loss and jaundice as early signs. The cancer of the body and the tail of the pancreas usually remain asymptomatic until it's well advanced. The pain becomes more severe as the cancer progresses. The tumor is diagnosed early and can be removed surgically, then we're good shape. So that's usually when it's in that head or in that neck of the pancreas.
Developmental change will peak between the ages of 20
All right. And then if not, if it's more in the body and the tail, then a lot of times we don't even know someone has it until it's well advanced and moved along there. These people can also develop liver failure because of obstruction of the hepatobiliary system. All right, next is lower GI. So celiacs, irritable bowel syndrome, inflammatory bowel disease, appendicitis. So celiacs, this is a malabsorption issue. All right, and it's because of the celiac sprue. Usually starts in childhood, but sometimes people don't recognize it until adulthood. It's genetic, and it's the intestinal enzyme that is missing that doesn't allow the gliadin to be digested. So this is a protein, this gluten, that exists in certain foods. We use the mnemonic brow. Okay, so usually the foods they cannot eat are barley, rye, oats, and wheats, which make up the brow mnemonic. It causes a problem in the villi. Remember, the villi are those finger-like projections in the ileum that help with absorption. Here, those finger-like projections will become atrophy.
It describes a major
Villi,
risk
please put
factor
yourself on mute.
associated with maternal
Please put yourself on mute. The villi atrophy, and that causes a decrease in the enzyme production, less area for those nutrients to be absorbed. So celiac causes malabsorption and malnutrition. Again, it's because of that enzyme that's not there to break down the gliadin. So for people with celiacs, they'll have steatorrhea or fat in the stool, okay? Muscle wasting, failure to gain weight, irritability, and malaise. And a lot of times we'll see this when we add cereal to the diet, so around 4 to 6 months old. And they'll need a gluten-free diet. So that is your get rid of the brow. Get rid of the barley, get rid of the rye, get rid of the oats, get rid of the wheat. Instead, they'll use corn and rice for the grains. Crohn's is next. You have to know the difference between Crohn's and ulcerative colitis. Both of these are considered inflammatory bowel disease. We don't know the cause for either one. 2 genes are identified which, if defective, are linked to Crohn's. In patients, especially with ulcerative colitis, There are manifestations of immune abnormalities, including iritis, ankylosing spondylitis, arthritis, and nephrolithiasis. There are many similarities between Crohn's and ulcerative colitis. Both occur in both men and women. Crohn's usually happens during adolescence. Ulcerative colitis usually happens when you're around 20 or 30 years old. Differences are characterized by remissions and exacerbations, as well as certain clinical effects. So with Crohn's, it will affect the digestive tract, usually the small intestines. This is a malabsorption problem. Ulcerative colitis is not. Crohn's can affect areas of the digestive tract, but mostly the small intestine. And because that is where most of the absorption takes place, it can affect absorption. There are skip lesions there, but there's also areas of normal tissue. Inflammation will happen in the mucosal layer. They'll have these little ulcers, and the ulcers form fissures that are separated by thickened areas, and they make it look like a cobblestone appearance. That's a test question all day. Okay. Inflammation and fibrosis here. So they have this thick wall, narrow lumen. The granulomas are usually because of chronic inflammation. The damaged wall impairs the ability of the small intestine to absorb food. Inflammation stimulates the motility, decreasing the amount of time available for digestion and absorption. So you can see this is clearly an absorption issue. Crohn's interferes with digestion and absorption. It can cause hypoproteinemia because you don't have enough protein. It can cause a problem with absorbing vitamins, malnutrition, and steatorrhea, so fatty stools because of the malnutrition issue. Adhesions can form in the intestines. These can penetrate the intestinal wall and cause abscesses to form. Fistulas can be found between the intestines or the intestine and the bladder. So these clients develop perianal fissures and fistulas. Exacerbation. So what are we going to see with Crohn's? Diarrhea with cramping abdominal pain. Stool is going to be soft or semi-formed. Remember that. Melena meaning dark, tarry stools if the ulcers erode the blood vessels. Pain and tenderness in the right lower quadrant. Anorexia, weight loss, anemia. These clients usually need TPN when they have a exacerbation. Malabsorption, malnutrition, delayed growth for kids, of course. Problems with sexual maturation because they lack certain proteins and vitamins. Again, remember they have that cobblestone appearance. It's affecting the intestines, so it's affecting absorption. With Crohn's, it can affect any part of the GI tract, okay? Remember those skip lesions, that cobblestone appearance. Ulcerative colitis is going to affect your large intestine. Okay, so the rectum usually doesn't touch the small intestine. So with ulcerative colitis, we'll have inflammation in the rectum, through the colon, no small intestine involvement for the most part. If it does, it's very rare. Okay. But the area where it is vascular, so that causes it to bleed easily. As the ulcers grow together, large areas of the mucosa become exposed to erosion. The tissue is destroyed there. That causes a problem with absorbing fluid, and it can cause a problem with electrolytes. I'm almost done. Oh, feels like you might have a little phlebitis going on there. Inflammation of the vein. Put some ice on it. Try to get that swelling to go down. All right. That tissue will interfere with the absorption of fluid and electrolytes in the colon. They can develop what we call toxomegacolon. Inflammation, impairment of peristalsis, so things aren't moving, obstruction and dilation of the colon. So this colon is going to become large. A toxomegacolon is considered a medical emergency because you have overdilation of the colon, and that can cause toxic things to go into your bloodstream, into your body. It could also cause tears in the digestive tract and sepsis. So you got to be careful with it. With ulcerative colitis, they'll have diarrhea, frequent watery stools. So remember, with Crohn's, the stool was soft. That means it's solid. It's not watery. They'll have blood and mucus in the ulcerative colitis. Okay. In Crohn's, they're going to have the tarry stool, meaning that you won't be able to see the blood. It'll be in the way of that black tarry stool. And also with ulcerative colitis, remember that you're going to have a problem with absorbing water and electrolytes, where with Crohn's, it's your actual nutrients from the food. And it can break down the fat sometimes. So these guys are going to have bloody, mucousy stools frequently during the day or night. They can have spasms of the rectum known as tenesmus. So it's tenesmus. And the rectal bleeding can contribute to iron deficiency anemia. They can have fever and weight loss. Irritable bowel syndrome. This is a GI disorder with abdominal pain, discomfort, changes in bowel habits. Usually these are based on sometimes people's like anxiety, emotions. So they'll have back and forth between diarrhea, constipation, pain, abnormal gastrointestinal motility and secretion. They can have either constipation or diarrhea. Usually they're hypersensitive to certain things, the environment. Sometimes after infection, they might have IBS that's associated with some sort of bacteria or overgrowth of flora. Again, these can go back and forth as to whether they'll have diarrhea or whether they'll have constipation. Food allergies could lead to this. And psychosocial factors like emotional stress, which causes the autonomic nervous system to function there and go back and forth. So for irritable bowel, they're going to have lower abdominal pain, diarrhea, and constipation alternating, bloating, nausea. They'll usually just treat it with some sort of antispasmodics. Appendicitis, you should know this. The main cause, right there, that first line, obstruction of the appendiceal lumen by a fecal lith or a gallstone. Fecal lith is poop, hard piece of poop. You got to know that. Fluid builds up inside the appendix. Bacteria starts to spread. The wall of the appendix becomes inflamed. Exudate that's purulent will form there. The appendix becomes swollen. Eventually, this appendix can burst. Those chemicals from the ischemia, those enzymes from the ischemia and necrosis can leak because of the increased permeability there. So we want to treat this. The bacteria and the toxins can escape into the surrounding area. Again, that can lead to peritonitis, bacterial peritonitis. What's your signs going to be for that? Who knows? What's your signs going to be for peritonitis? That's going to happen if that appendix ruptures. And how will you know? Because usually they'll have a sudden relief of pain. And then they'll become very sick and possibly die if you don't correct this. So I hope you know those signs of peritonitis. I'm not going to say them again. I've said them about 4 times. You should be able to repeat them back. They're going to ask you about those. So these clients are going to have pain. Okay, severe and localized in the right lower quadrant. The right quadrant tenderness usually develops at a place called McBurney's Point, which is between the umbilicus and the iliac crest. Usually, if you push straight down there and release your fingers, they'll have what we call rebound tenderness there. Again, pain recurs as steady, severe abdominal pain as peritonitis develops, low-grade fever. Signs indicating onset of peritonitis are rigid, board-like abdomen, tachycardia, and hypotension. Periumbilical pain, so pain around that belly button because of the stretching of the appendix. After rupture, the pain subsides temporarily. Pain then comes back as severe abdominal pain as the peritonitis develops, low-grade fever, leukocytosis, and then the peritonitis. And these toxins are being absorbed, and that causes a reduction in the blood pressure. Diverticulitis, this is where you have development of diverticuli in the intestine. These are little outpouching in the mucosal layer. Usually it's diverticulitis is asymptomatic diverticulosis. When it becomes diverticulitis, then it's actually inflammation. So diverticulosis, asymptomatic, diverticulitis, inflammation or exacerbation. Here you have these little pouches or diverticuli that form, and this allows weakness there in the wall. It causes the wall to pouch out. And then food like corn, nuts, seeds get stuck in there. So complications can be obstruction of the intestine. It can perforate the intestines because of the pouching and the weakness and cause peritonitis or abscesses. A lot of these clients are asymptomatic. If they start to develop something, it's going to be things like abdominal discomfort, usually on the left side, diarrhea, constipation, flatulence. And usually it's because of either the feces itself being stuck in the pouches or food. Again, lower left quadrant cramping or pain with tenderness, slight fever, elevated white blood cell count. Diverticulosis is when you have the small pouches inside the walls. They develop because of the weak spots in the outer wall. The pouches themselves are called diverticuli. They occur in the large intestines. You're more likely to have weak spots there, especially towards your sigmoid colon. Diverticulitis means there's inflammation in one of those pouches. Colorectal cancer. This is considered a lethal cancer in people over 50. It's the second leading cause of cancer deaths. A lot of these can be prevented by having colonoscopies done, where they look for things like polyps and malignancies. Most malignant tumors develop from the adenomatous polyps. This is a mass on a stem that protrudes into the lumen. A lot of them come from genetic abnormalities. As the polyps grow, they put you at risk for dysplasia or abnormal cells and malignant changes. These adenocarcinomas are distributed equally in the right or ascending colon and the left or descending colon, and as well as the sigmoid and the rectum. We see a lot more in the right colon. They're more difficult to diagnose at an early stage just because of the natural shape of the body. These type of cancers mostly happen in people over 50. So that's when you start getting those colonoscopies, unless you're at risk. Sometimes they'll do it around 45. Diets high in fat, sugar, and red meat are considered contributing factors. So most of these cancers are asymptomatic until they're well advanced. Clients will have changes in the bowel habits like alternating diarrhea and constipation, bleeding indicated by occult blood or melena. So again, it's going to be hidden in the stool or that dark tarry stool. Frank red blood and mucus on or near the surface usually indicate bleeding from the rectum itself. Most cancers will release cancer antigen. It's called CEA. It's a cancer antigen into the blood. So they'll also look for that antigen to screen. The problem is that can be elevated in other conditions as well. So this is just showing you the locations of the stool, of the intestine and what to expect. Where's my ascending? Where's my transverse? Where's my descending? Where's my sigmoid? You should know that. What kind of stool would I see there? What kind of signs would I see there? So take a good look at this slide here. People can also have obstruction of the intestines where things aren't moving through. The most common is in the small bowel. Depending on the cause and location, it can develop acute or slowly. So if it were to twist, that would cause a sudden obstruction, but a tumor might cause a slower obstruction. Mechanical obstructions come from tumor, adhesions, hernias. Functional obstructions come from neurological impairments like spinal cord injuries or lack of propulsion into the intestine. And these are often referred to as paralytic ileus. With intestinal obstructions, we have gas and fluids accumulating. The gas can come from swallowed air, but also from bacteria in the intestines. They may have strong contractions of the intestine. in an effort to try to move the content. Increasing pressure can cause more secretions to enter the intestine and also compress the veins there, preventing absorption and contributing to edema of the intestinal wall. The intestinal distension can also cause persistent vomiting. So that can lead to dehydration, loss of fluid and electrolytes. The body wouldn't be able to reabsorb the fluid and electrolytes, and that can lead to things like hypovolemia. Also, if we don't remove the obstruction, the intestinal wall itself will lose the blood supply, and that could cause it to become ischemic or necrotic. And so we would have to remove that part of the intestine in order to get, supply to go through there again. If twisting occurs, that can happen with a volvulus or with something called intussusception. And that can cause obstruction and also necrosis and gangrene of the intestines to occur. Usually with any of those things, you're going to see a decrease in bowel sounds. So that's why you should be listening to bowel sounds for a certain period of time. Intentional distension causes vomiting, loss of fluid and electrolytes. The body cannot reabsorb and hypovolemia develops. Ischemia and necrosis can lead to decreased innervation and a lack of peristalsis. A decrease in bowel sounds would indicate that. Obstruction promotes rapid reproduction of intestinal bacteria, which can cause the production of endotoxins. The wall becomes more permeable, so bacteria and toxins can now leak out into the peritoneal cavity, leading to peritonitis or septicemia, and it can cause perforation of the wall, which would definitely lead to peritonitis and septic shock. And these people may not be able to recover. Some other functional things could occur. Paralytic ileus or some sort of neurological impairment from a spinal cord injury. Sometimes peristalsis stops because of obstruction, spasms. Again, these things can lead to inflammation, ischemia, and other problems. Hernias or strictures caused by scar tissue can cause these obstructions. Tumors, intussusception, a volvus, Hirschsprungs, which is something that some babies are born with, and then gradual obstruction from some sort of inflammatory condition. Obstruction of the large intestines. This can develop slowly. Usually the symptoms are more mild. They'll have constipation, lower abdominal pain, distension, anorexia, vomiting, and eventually more severe pain if we don't fix it. So just take a good look at this slide. Again, because the body's trying to push it out, it's going to cause that colicky pain because of the spasming of the body trying to push with that pressure. Peritonitis, I went over this a couple times. There's different types, okay? Here you can have chemical peritonitis where you have enzymes from the pancreas leaking, from a ruptured bladder, chyme from an ulcer, bile from the gallbladder, blood, or anything else getting into that peritoneal cavity. It doesn't like anything else in there. All right, so this is just showing you some ways, chemical or bacterial. We really went over most of this, so just review it. With bacterial peritonitis, this can be caused by trauma, a ruptured appendix, or some sort of obstruction in the intestines. If the foreign material is left or infection develops from abdominal surgery, or from pelvic inflammatory disease. We'll talk about that more when we give it into reproductive. So here the infection spreads along the reproductive tract and it ends up getting into the fallopian tubes, okay? And then it's able to get into the peritoneal area. So we'll have necrosis. Well, first we'll have inflammation of the peritoneal membranes from whatever has gotten it inflamed. That causes increased permeability in the intestinal walls that allows the bacteria to enter the peritoneal cavity. When the inflammation develops, the peritoneum tries to produce a thick, sticky exudate to help everything stick together. The inflammation can reduce peristalsis in the area and decrease the risk of spreading the toxins or the bacteria unless the original cause or problem is resolved. The inflammation or infection will then continue to spread. So first the body will try to protect itself, but it can become, overtaken or over exaggerated, and then the body is no longer able to fight here. These clients are going to have abdominal distension, a rigid board-like abdomen because of the abdominal muscle spasms. Vasodilation and increased permeability, allowing things to leak into the peritoneal cavity. Hypovolemic shock, because the fluid is going to leave the vessels, go into that area of the peritoneal cavity. Fluid, protein, and electrolytes in the peritoneal cavity are not put back into the circulating blood, so the body cannot use them. As the infection spreads, the fluid becomes purulent. Nerve conduction is impaired. Peristalsis decreases, causing a paralytic ileus. And then the inflamed membranes allow that intestinal bacteria and the toxic materials to go back into the blood and into the circulation, causing the client to develop septicemia. So now the bacteria is actually in the bloodstream. So bacterial peritonitis can be caused by trauma of the intestines from an injury or being ruptured, like during a colonoscopy, a ruptured appendix, an intestinal obstruction, chemical peritonitis from pancreatitis enzymes, from urine leaking, from chyme in the peritoneal area, from bile, from a damaged gallbladder or perforated gallbladder. Abdominal surgery can lead to this. Pelvic inflammatory disease can lead to peritonitis. That's it. Questions?
Thank you.